Rob? Can I call Pietro?
First one is pointed forward.
This is pointer.
Yeah, forward.
Forward.
Yes, forward. You have to hold the pointer.
Dear friends and colleagues, we are honored to have AANA participation in the 8th International Congress of EGAA. And we hope to build a strong bridge between EGAA and AANA, also between EGAA and other associations. I would like to introduce to you my friend Professor Robert Hunter, Director of Orthopedic Sports Medicine Center and the Orthopedic Center of Excellence at Hearts of the Rockies Regional Medical Center, Colorado. He is also past president of Arthroscopy Association of North America. Also, I would like to introduce to you my friend Professor Pietro Tonino, Professor of Orthopedic Surgery and the Director of Sports Medicine Program at Loyola University, a chairman of the International Committee and the board director of Arthroscopy Association. Thank you very much. Welcome, Rob. Welcome, Peter.
Thank you. Thank you very much. It's both a pleasure and an honor to be here at the EGAA meeting. I was here last year, actually, and my take-home was it was one of the very finest arthroscopy meetings that I'd ever attended. Actually, the international speakers are fantastic. The Egyptian speakers are fantastic. And the whole meeting is in English, which I thought was remarkable because I could actually sit and listen and understand and learn. So I'm very, very honored to be back this year to be with you. And I wanted to take a minute to talk to you about the Arthroscopy Association and our goals and objectives in participating with you this year. Forward. Yeah. First, a little bit about the Arthroscopy Association. The mission of AANA is to seek to advance the art and science of arthroscopy and minimally invasive surgery through education, through self-assessment, and through advocacy. AANA is an international society of more than 5,500 orthopedic surgeons that represent over 112 countries now, all of whom are committed to the field of minimally invasive orthopedic surgery with the goal of improving outcomes. And I'm happy to say that we have a number of members already in Egypt, and we're very, very proud of that. One of the cornerstones of the Arthroscopy Association is collaboration. In fact, we collaborate very closely with the American Orthopedic Society for Sports Medicine. We used to compete bitterly, and now we collaborate because we find we can get a lot more done if we work together. So collaboration is a real cornerstone for us. We have collaborated with 11 subspecialty societies to work to advance arthroscopic surgery. We have worked with and been present in 8 international meetings in the past year, including, I'm happy to say, Cairo, Egypt last year, and again this year. So we're thrilled by this relationship. I want to talk to you a little bit about our international members. The largest growth in our membership is through our international members. And so we're very keen on that, and we're promoting our international membership very aggressively. I want to talk about the benefits to you of being an international member. If you're an international member of AANA, you get access to courses both live and online. There is discounted registration for our annual meeting, which I'll talk about in a minute, our specialty day, which I'll talk about again, and the AANA laboratory courses, which occur in Chicago, and I'll show you our learning center in Chicago in a minute. You have free access to our arthroscopy journal, the Journal of Arthroscopy and Related Surgery, as an electronic journal. You have access to member-only scientific and technical resources through the website. You can apply for and receive any scholarship, any traveling fellowship, and any grant that is being offered by the Arthroscopy Association. There is no discrimination or differentiation between an international member and a member from the United States. You have equal access to all of that. You have access to all the membership, 5,500 members around the globe. And you can also serve. In the Arthroscopy Association, if you're an international member, you can serve on committees, you can chair committees, you can serve on our board of directors, you can be elected to our presidential line, you can serve as president of AANA as an international member. So there are no restrictions and no differentiations between our international members and members from the United States. So we're very, very proud about the fact that this has become a very open, inclusive organization. Our fee for an international member to join is $150 US per year. And we've tried to lower that to the point where it's not a financial burden and allows people a good access and resource to the Arthroscopy Association. The Arthroscopy Journal, I just want to talk about for just a second. It's a great place for you to submit manuscripts. I would say, my bias, in the United States, there are two great sports medicine / arthroscopy journals. The Arthroscopy Journal, which I'm alluding to here, and the American Journal of Sports Medicine. Fantastic journals, both. We are obviously biased towards the Arthroscopy Journal. It focuses on arthroscopy exclusively. It's a very prestigious international journal with an impact factor of 4.3, which is actually very high. It's the fourth highest impact factor in the orthopedic section, and we think it's the highest impact factor of subspecialty journals that specialize in just one thing, such as arthroscopic surgery. So we're very proud of the journal. We would encourage young, even old, authors who are trying to get their work published to consider the Arthroscopy Journal. In addition to that, like Bruce Ryder just talked about, we have developed open access opportunities for readers and viewers. Arthroscopy Techniques is our video journal. These are peer-reviewed, referenced articles and videos that last up to but not longer than 5 minutes. They're a great way, for example, if you want to review a video or 2 or 3 before you do a case, before you go to the operating room. It's a wonderful way to catch up with the latest techniques as presented by and reviewed by and supported by the arthroscopy publishers and publication team. We have started a podcast. The Arthroscopy Podcast is free. It's available through iTunes or Google Play Music, and you can simply download the iPods, podcast rather, and listen to them as you wish at no cost. Finally, I want to introduce you to a new journal that we have begun in 2019 called the Arthroscopy Sports Medicine and Rehabilitation Journal. This is also an open access journal, which we're very excited about. We're anticipating that we will have enough journals, enough articles within the journal system to be referenced sometime in 2020, this year, we're hopeful. But this is a great access for you as both a reader and someone who might want to publish an article. It's open access and it's free to use for you. Let me mention a word about our Orthopedic Learning Center. We have a very modern, sophisticated Orthopedic Learning Center in Chicago. We began the process about 20 years ago. We moved into this new facility a few years ago. We're very proud of this. And it's a place where we can teach skills and really do hands-on work in a cadaveric setting. You can see that we have 24 very well-equipped laboratory stations that allow us to do one-on-one teaching between you and your lab instructor. So you can really gain a great deal of information and a great deal of technical skill if you come work with us for a weekend at one of these lab sessions at the Learning Center. This is just a list of some of the things that were presented last year to give you an idea of the scope. We did a patellofemoral and joint preservation course, shoulder solutions and for bone loss, rotator cuff repair, advanced knee ligament, meniscus and articular cartilage, and advanced hip arthroscopy. So we're covering a lot of different areas. Every weekend is a different focus and a different joint, so you can look to see what's being offered at the Learning Center. Come over, take the course, enjoy yourself. This is in Chicago, which is a wonderful international city. I'm sure many of you have already been there. So please take advantage of that. And if you are an AANA member, you get discounted rates to attend those courses. Our specialty day this year, as it has been for the past few years, is a joint specialty day between AANA and the American Orthopedic Society for Sports Medicine. So I think this is the best of sports medicine and arthroscopy in the United States, put together for a very ambitious specialty day. I just lost my slides. Let me get those back real quick. It's held in conjunction with the Academy meeting, as you all know, and you can learn about the latest advances in arthroscopy, review basic knowledge and skills in arthroscopic surgery, and update your knowledge about recent research in the field. So we hope that we can see you there in Orlando this year. Our annual meeting is in Dallas, Texas in May, and again, we would encourage you to come visit and attend our meeting if you can. If not, just a heads up that the meeting next year in 2021 will be in Chicago, which is a very, very easy place for you to get. And we're very excited about being back in Chicago for that meeting. We would encourage you to come join us there. You can follow us on social media. It's kind of fun to do that. Now, we have a booth here. Laura Downs is our CEO. She is here with us at the meeting, and she will talk to you and help you through the process of applying for membership. You can do it right there. There's no other paperwork to do. You can do it on a little iPad, and you're good to go. So please come join us out at the booth if you have any interest or questions about becoming a member of AANA. Thank you very much.
The next talk by Professor Pietro Tonino, slab tear, fact or fiction. أنا بس عايز أبلغ حضراتكم بإن البوست بتاع الأنا ممكن أي حد يعمل عليه ريجستريشن للممبرشيب اللي يرغب إن هو يكون ممبرشيب.
I'd like to thank all our video people who help us with these presentations. I think for an arthroscopy meeting, they are probably the most important people here. I'd like to thank again Adel, my friend, and all the organization committee here who are helping put on what is looks like a very successful meeting. My topic today will be about slap tears. Here are my disclosures. In 2010, Dr. Weber published a study showing that young orthopedic surgeons were doing too much slap repairs, and the number of slap repairs were actually 3 times the actual incidence of slap tears reported by Dr. Steve Snyder. Not only was it a problem with the surgery, but the high complication rate, only 26% of patients were pain-free and only 13% were functionally normal, so there were a lot of problems going on 10 years ago. Maybe those results were not very good because the surgeons were very young. So what are the experienced surgeons, what are their results with SLAP surgery? And if you look at most of the literature, the results with SLAP repairs is not very good. This study in 2009 showed pain and stiffness with SLAP repairs, 37% unable to, 55% unable to return to sport, and 37% were not very happy. And the problem is not that the repair maybe doesn't work, but that many times there are complications as a result of the SLAP repair. The patient becomes stiff, they need a capsular release. The anchors, they come out, so you have to have another surgery to remove an anchor, and maybe they need a second surgery with a biceps tenodesis. If you look at overhead athletes, particularly with SLAP tears, where this is fairly high incidence, only 38% have returned to playing baseball in this study in 2013, and other studies have shown very similar results. We'll talk about that later. So I think even today, we still don't understand completely about the superior labrum, and many times among same doctors, you don't agree. You look at the MRI, you look at a video, you can't agree if there is a SLAP tear or not. So let's review the anatomy. So I think overall, you need to understand that the superior labrum is different from the anterior labrum because the top of the labrum is more of a discoid meniscus and looks different in this area right here. This is different from what it looks like on the patients for their anterior labrum. And there's an articular cartilage covering here that's different from the anterior labrum. So the superior labrum has a little cleft, and the articular cartilage can cover this area. And so if you try to repair that, the labrum cannot heal to articular cartilage. And if you take off the articular cartilage, probably it's not a labrum tear. So the anterior inferior labrum is different because there's direct attachment of the labrum to the bone and the glenoid. The vascular anatomy, the blood supply of the superior labrum is different also from the anterior inferior labrum, usually less blood supply, and this may explain why some of the SLAP tears don't heal, particularly in older patients because this vascularity becomes less as they get older. And there's a lot of anatomic variability. There's a sublabral recess in this area. Many times patients have sublabral recess, sometimes they don't. The Buford complex, the cord-like middle glenohumeral ligament. If you do a repair in this area, many times because you don't recognize normal anatomy and you repair what you call a SLAP tear, the patient can have stiffness in this area. So be careful. The etiology of what causes SLAP tears we don't understand very well. In overhead athletes, Dr. Andrews published that it may be from traction on the shoulder during the follow-through motion of the baseball throw or overhead motion. It can be the same for tennis serving too, or volleyball. Dr. Snyder talked about falling on the arm as being a traumatic cause of superior labral tears in 1990. Dr. Morgan and Burkhardt talked about the peeling lesion from reaching back for overhead athletes, and it peels off the labrum posterior superiorly. So a peeling of the labrum. And Dr. Meiser talked about the GERD or contracture of the posterior capsule that can force the humeral head posteriorly superiorly, which can cause damage to the posterior superior labrum and cause the detachment of the labrum in this area. We see SLAP tears not only in athletes but also in workers. People do repetitive overhead lifting, and then people can get acute injuries. You are lifting a patient, a nurse lifts somebody, the other person doesn't help, she is holding, and the arm gets pulled down like that. Acute SLAP tears. How about the evaluation? There's really no good clinical test. That it's been shown in many studies that there's no good clinical test for SLAP tears, so it's very difficult to diagnose on a clinical examination. Some people use the O'Brien test, some people the relocation test. Diagnostic testing, I think MRI, arthrography is probably what we feel is the best test, but in overhead athletes, many overhead athletes have abnormalities of the labrum in asymptomatic shoulders. So don't be kind of fooled into saying it looks like a tear, and don't get an MRI too soon, because if you want to find a tear, especially in an overhead athlete, you get an MRI, you will probably find some sort of tear, but it may not be important for the patient. And so try physical therapy before you send the MRI. Many places I go, people get MRI right away, do conservative treatment, physical therapy, and then get an MRI if they don't get better. So when you see something like that, here's what they call a slap tear on the report, but maybe this is what you're looking at right here. If you see a paralabral cyst, I think that's more of an indication that the slap lesion you're looking at, or potential slap lesion, is really a true tear, because that tells you that something has been going on there for a while, and a paralabral cyst can help you define what may be possibly a more significant slap lesion. How about the treatment? A lot of discussion about treatment for that. Before you consider surgery, as we talked about before, make sure you try with physical therapy first, dyskinesis, look for scapular dyskinesis, core strengthening, injections, rotator cuff strengthening, and then if they don't get better, then get an MRI. Then you will not be fooled by the MRI so many times. I think there's a lot of agreement about degenerative tears. You can clean up degenerative type slap tears. Buckle handle type tears, sometimes you can repair it in younger athletes, but maybe in younger patients, but maybe tenodesis or tenotomy may give you a better result long term. If it goes into the biceps like there, I've done repairs in very young athletes, but in older patients, sometimes tenotomy or tenodesis is probably a better treatment. What about type 2 slap tear? Do we repair, do we not repair? There have been several studies, including more recently in 2018, that show that compared to repair, tenodesis may actually be a more cost-effective treatment, considering that some of the repairs don't heal, and then you need to do a second surgery. Maybe doing bicep tenodesis may be the best treatment. Overall, I think that your results will be better if the slap tear was from a traumatic event and not from an overuse or repetitive type trauma. Usually we talk about repair in younger patients, maybe under 40, under 30 probably, under 20, yeah. I think most younger athletes like that, younger patients, need to have a repair. And if you see a posterior superior labral tear like this in an athlete, and especially if you see like a paralabral cyst in that area, I think it's probably a good idea to try and repair that. If you have if the slap is part of a panlabral tear or a big labrum tear, then I think you should repair it. And again, I think the paralabral cyst for me is helpful to tell me maybe to think about repairing. Older patients, more than 40, 50 years old, probably not as good. They're more non-traumatic, degenerative type tears. They don't have as good vascularity. Maybe bicep tenotomy or tenodesis is better. A technique, using good technique, limited debridement. Don't debride the labrum too much. Don't remove the normal articular cartilage. If you're looking, you see, oh, slap tear, and you look here, and you see normal articular cartilage, stop. Maybe it's not really a slap tear. You know, look for something else. You can put percutaneous anchors through the rotator cuff, medial through the rotator cuff. And you can use knotless anchors, but you can use knots also. Just keep that away from the articular surface. And be careful not to put the anchor too close to the biceps. You don't want to strangulate the biceps. I think you have to be very, very careful, we talked about in this area here. Don't pull up the capsule and don't do too many repairs in this area, because I think if you're repairing a normal sublabral foramen or you're putting a lot of traction, you can create some stiffness and external rotation, and then you have to go back in and do a capsular release. There have been some reports of the anterior superior labral tear can damage the suprascapular nerve. It seems impossible, but there have been a couple demonstrated studies, so make sure you are seeing where you are putting the anchor. And remember that in overhead athletes, it's not only a slap tear. Many times there are other problems as well. They have partial thickness tears. Do you debride them? Do you repair them? I think Dr. Castagna is going to talk about repairing that. And many times they have microinstability. Do you plicate the capsule a little bit in addition to repairing the slap tear? So it's not that simple as a repair of the labrum. There may be some other things going on as well. And if they have those partial lesions, only 12% of them will return to. So if you see a slap tear and a partial rotator cuff tear, many times they cannot return to sports, the type of sports they were doing before. And I think it's always important to look for scapular dyskinesis. Take the shirt off of the patient and have them lift the arm up so you can look at them from behind, so you look to see if they have any scapular dyskinesis. In this study, published 1 month ago in the physical therapy literature, they showed that all baseball players who went to see an orthopedic surgeon with shoulder or elbow pain, all of them had scapular dyskinesis. And sometimes we do Job tests, Hawkins tests, but we don't look in the back for the scapular dyskinesis. Important. Post-surgery, usually rest pendulum for about 3 weeks and then start scapular pain, range of motion, and external rotation, strengthening, work on your scapular kinematics, work on the core. And for overhead athletes, particularly with pitchers, we really want to look at their mechanics and look at how they're throwing. Maybe they use their arm in a bad position. If they do bad mechanics, they can re-injure their shoulder again. So what are the conclusions? I think the superior labrum is different from the anterior inferior labrum. They're not the same. And the good results we see with Bankart repair, we don't see them so much with slap repairs. We can probably improve our results by not fixing something that's not torn. So don't repair a normal anatomy. And it's important to advise the patient before surgery. This is very important, right? Because we have a lot of lawsuits in the United States from patients who are not happy. So if you explain to the patient, the MRI shows a slap tear, many times it's not really a slap tear. We will look inside to see if it's slap tear. Then you have to trust my judgment. If it's torn, I will repair it. If it's not torn, I won't repair it. And I may have to do a biceps tenodesis. You must explain that to them. Because all they see on the MRI is slap tear and why you did not fix it. Consider repair for traumatic type 2 slap tears. So acute traumatic tears, probably better results than the chronic slap type 2 tears. And when you have an athlete that's younger like that, many times it's better to do a repair. You try and preserve the labrum as much as possible. So repairing, putting stitches in there, repairing. This was a 15-year-old patient. So if you look, kind of a big tear in this area. Extending anterior inferiorly. Not very pretty for a 15-year-old patient, but I think we try to repair, put some stitches, and hopefully they get better. So we put some stitches in the front and in the back there. Over 45 to 50, probably biceps tenodesis or tenotomy is better and gives you a more reliable result. And again, explain to the patient that you may do a tenodesis. You will cut the biceps, you will move it in a different area so they understand what you're going to do. They think they're going to do a slap repair, so you have to explain. If we don't repair, we will do a biceps tenodesis. Especially if you're going to do a tenotomy, because then if they get the Popeye, they're not so happy. If that doesn't work the first time, I don't think it's a very good idea to try and repair it again. You should do a biceps tenodesis the second time. That's been shown in multiple studies. And finally, don't be too aggressive with slap tears in overhead athlete. It's possible that detachment of the labrum is necessary because if you look at the baseball player, the tennis player, the volleyball player, their arm must rotate externally. I cannot do it because I don't throw baseball very fast. But in the athletes, they can externally rotate. Maybe it has to detach a little bit to allow them to externally rotate so they can internally rotate. And maybe the pain is not from the slap tear. Maybe it's from a partial cuff tear, maybe laxity, maybe something else. And this has been borne out by Jimmy Andrews, Dr. Andrews, who treats a lot of baseball players in the United States, who says that in pitchers it may be better to do little or nothing at all with slap lesions. Thank you.
Thank you, Professor Pietro, for this nice presentation. And the next talk is ACL. Is there an ideal graft and fixation method? By Professor Robert Hunter.
I think we'll stick to just the graft material so we have some time for discussion maybe. So I'm going to, is this one? Yeah. I think we'll switch the topic just to talk about the graft material. This was talked about a little bit yesterday, but I want to give you my impressions about this and how best to proceed. These are my conflicts. And if we talked about the material, this is part of a successful ACL. If you think about what's required, three things really: putting it in the right place, having something strong, and then fixing it well gives you the best chance. So we're not going to talk too much about putting grafts in the right place, although I think that's an interesting topic to discuss. We're not going to talk too much about fixation, although I think fixation clearly matters and how we fix things does matter. But we'll focus mostly on graft material. This was a study about 9 years ago now that came out that showed that ACL allografts failed 4 times more commonly than autografts. And it almost stopped allograft surgery from happening. And yet, if you looked at material from about the same time, it was inconsistent with what other people were seeing. In this study, for example, from '09, this author, looking at 100 ACLs, found no difference in objective results, no difference in Lysholm scores, comparing an autograft with an allograft reconstruction. It seemed odd that they would be so different. Kretsch was one of the first people to do a meta-analysis looking at BTB autograft compared to BTB allograft, and allograft. And what he found was this, that allografts were more likely to rupture than an autograft, and this statistically significant difference. However, when irradiated and chemically processed grafts were excluded, there was no statistical difference in rupture rates between allograft and autograft. And that became, to me, a critically important finding that we'll go over. And in fact, if you go back and look at the study that was published in 2011 with a higher incidence of allograft rupture, there was no breakdown from the standpoint of the type of allograft tissue, BTB versus soft tissue, nor was there any discussion about how the graft had been prepared, whether it had been irradiated or chemically sterilized as part of the technique. And I'll make a comment about that in a minute. This is a very powerful study that was published in 2012. It's a multi-center, prospective, randomized study examining autograft versus allograft ACL reconstruction. The allografts were fresh frozen, non-treated in any way. And what they found was that there was no statistical difference in stability, in the IKDC score, or a reoperation rate between allograft and autograft. Very powerful study. We look at this allograft, autograft, non-irradiated concept. This was a systematic review of both prospective and retrospective studies. The level of evidence was 1, 2, 3. So it was a much broader look at this particular problem. And what the authors found, I'm trying hard to turn the page here, but I'm not being successful. What am I doing? Here we go. When the authors looked at the data, what they found was that autografts versus non-irradiated allografts in the literature, there was no statistical difference between autograft and non-irradiated allograft in any outcome measure that they used. They did, however, provide a little bit of caution. They said that these findings apply to patients in their late 20s and early 30s, and we have to be cautious applying these findings to younger, more active patients. And that may be still true. On the other hand, this is a paper by Tom Carter that was published a couple of years ago looking at his experience with 43 patients, and the age range in his group ranged from 11 years old to 24 years old with an average age of 17. These were non-irradiated grafts. And what he found was that his failure rate was 2.3%, one failure, and 92% had an IKDC score greater than or equal to a B. So very, very successful outcomes in the younger population. I apologize for the fact that my clicker, something's either wrong with my thumb or something's wrong. There we go. Look at this study, risk of revision after ACL reconstruction with soft tissue allograft compared to autograft. In non-processed allograft, they did not have a higher risk of revision. And this is the Kaiser Permanente ACL register, a very large registry of ACL cases in the United States. And their conclusion was that there was not a higher risk in this large population, over 14,000 cases. This is consistent with this study. This is comparing autograft and allograft. And I would say this. If you're going to look at allograft versus autograft, look at the literature and decide what you're going to do. Number one, you have to look at how tissues were handled. If you're reading an article, you need to know how the allograft tissue is handled. Number two, if you're using allograft, you must know how the tissue was handled, how it was managed, so that you know exactly what you're dealing with. And I would make these conclusions based on the literature. If you use aseptically processed, non-irradiated tissue without bioprocessing of any kind, you should have outcomes equal to autograft tissue. That's a pretty bold statement, but the literature would suggest that that's true. And this becomes my choice, my choice for ACL reconstruction over patients over 25 is allograft tissue, and my results have been quite acceptable. I'm really sorry here. What about hamstring versus BTB? There was a French author who just last year said graft choice is secondary and not really a key to success. It didn't matter if you used BTB or hamstring. And I'm not sure that the literature supports that conclusion. Man, I apologize. I'm having a hard time with this remote. If you look at this meta-analysis, this was the first meta-analysis done looking at patellar tendon versus hamstring autografts. And if you look at the outcomes measured as return to play and return to pre-injury activity, you can see I'm struggling. There. You can see that in the red box, these are patellar tendon grafts, and these studies favored patellar tendon grafts, and the conclusion was there was about an 18% greater chance of return to pre-injury activity using patellar tendon versus a hamstring graft. The Scandinavian registry, I think Bruce Ryder referred to this yesterday. It's a very large population, 45,000 plus ACL reconstructions. And they found in their data that there was a lower risk of revision with patellar tendon autograft compared to hamstring autograft. And this data was supported by the Swedish study looking at 5,000 different ACL reconstructions. And what they found was that the hamstring had a greater failure rate. Hamstring had a better return to range of motion, but BTB was recommended for high demand patients. And this is just from last year. So I think there's some pretty compelling evidence in the literature that suggests that that BTB might be a little bit more effective, particularly in a higher demand athletes. The question is, why are hamstrings inferior? And one of the findings that was made by this multi-center study looking at failure rates of ACL was that graft diameter was a significant predictor of risk of failure. And if you looked at the hamstring population that they studied, what they found was that only 25% of the grafts that were hamstring grafts were actually larger than 8 millimeters in diameter. And if you looked at their failure rates, you could see that 8 millimeters was really the cutoff. 8 millimeters and less had a very high failure rate. Above 8 millimeters had no failure rate. So it could be that hamstrings are more inferior strictly based on their size and nothing related inherently to the tissue itself. And I think that's probably true. One of the ways that I have solved this problem for me is I don't use the gracilis tendon anymore. I use a quadruple semitendinosus if I'm going to use a hamstring. And if you quadruple a semitendinosus, the graft is shorter, but for me it's typically about 70 millimeters, and you only need about 55 millimeters of graft to do a good fixation on both sides. So I have usually a long enough graft, and I almost always get a graft that's larger than 8 millimeters in diameter, even in a small person, because the semitendinosus, as we all know, is a larger diameter graft than the gracilis tendon. So you'll get a bigger tendon if you just use the semitendinosus and quadruple it. So this is my choice for young patients with open growth plates, where I'm worried about a bone graft crossing a growth plate. In young quad dominant athletes, for example, skiers and snowboarders, if you do a skier with a patellar tendon, they can get anterior knee pain, which makes it more difficult for them to ski. They're stable, but they hurt. And I will use it in patients with patellofemoral pathology and or pain preoperatively, because I don't want to contribute to greater pain postoperatively. On the other hand, bone tendon bone is my preferred graft for young, high-demand athletes. I think it's the most stable and has the highest return to sport. There is a risk of anterior knee pain, so this is my choice for young, high-demand athletes with closed or near-closed growth plates. In other words, that 18 to 25 age group, bone tendon bone becomes my choice of graft. One word just about the quadricep tendon. I don't have any personal experience with quadricep tendon, frankly, but if you look at the literature, there's very good evidence that suggests that the quadricep tendon does just as well as hamstring and perhaps even bone tendon bone, as shown in this article, that a systematic review from last year showing that a quadricep tendon autograft had comparable clinical and functional outcomes and graft survival rates with the other two tissues. So perhaps it's a good option, but one that I'm not familiar with. Thank you very much for your attention. It's a great delight to be here.
Thank you very much, Professor Robert, for this excellent presentation. And we now will open the discussion for any question. Any question for Professor Pietro or Professor Robert? Professor Bassem, please. Okay. Microphone, yeah. Yeah, microphone.
I have a question about the slap lesion.
Slap.
We face mostly slap lesion combined with other pathology, mainly impingement syndrome with subacromial narrowing or instability. Do you see any vision in just treating the impingement syndrome, doing decompression and leaving the slap lesion in case of impingement, or in case of instability, if you make whatever procedure with after immobilization, you have any experience with just doing abrasion at the insertion of the biceps and leaving it to heal with the immobilization you do with the instability?
I'm not sure I understand your question. Can you repeat it for me, please? So a slap tear.
If you have a slap lesion with impingement syndrome and subacromial narrowing.
Yes.
Okay, and then you have a slap lesion with instability. So if you do the surgery, would you do a subacromial decompression and repair of the slap lesion, or just a subacromial decompression and leave the slap lesion? And in case of instability, do you do a abrasion at the insertion of the biceps on the glenoid, because you do an immobilization after that?
I think if I understand, if I have a patient who has impingement, who I clinically think I has impingement. So what does that mean? In my clinic, they have pain when I test the rotator cuff. I injected their subacromial space and they felt better. For that, to me, it indicates some sort of pathology in the subacromial space. If I find a slap tear in that patient, I'm probably not clinically going to think about the slap tear as much. I will be more looking for impingement, decompression, yes or no decompression. That can be controversial. If I find, the only reason I do decompression if I find some abnormalities in the subacromial space. So I have to say, if the slap tear is part of an instability thing like you're talking about, I repair this. I don't just abrade it. I guess if I'm going to repair it, I will abrade it, stitch it, and repair it as part of the instability surgery.
Yeah, I think that's, I would agree with that. If there's an instability problem and the labrum is detached, I would do a labral repair, including a detached superior labrum as part of the instability operation. But for impingement pain or rotator cuff pain, I don't incorporate a slap repair. You know, the thing is, how many people here have, well, let me ask it this way. I'll say this. When I get MRIs of people over the age of 40, 100% of those patients are diagnosed with a slap tear by my radiologist. 100%. Talk about a slap tear, and then I've got to explain to people that this is part of a normal aging process. This is just a normal finding inside your shoulder. Don't worry about it. It's like a little bit of a degenerative meniscus tear in a knee. And in those people with a slap tear with impingement, I look for other sources of pain, and I don't worry at all about the labrum at all. I might debride it on the way by, but I will not fix it at all.
I agree. Sometimes you spend half your appointment time talking to the patient about the MRI. Don't get the MRI. Don't get the MRI unless you're ready to do surgery. Make sure you try conservative treatment first, and don't get MRIs unless you really need to get them.
The problem with slap tears is that we all, and I'm a victim of this too. When you're doing arthroscopy, as you're learning or as you're finding something new, the fact that you can see it and find it means you should probably fix it, you know, and you don't really have any rationale for fixing it, except that you can see it and it looks like it's torn, so you fix it. And it's not till you look at these afterward that you realize these people that you fixed are painful and stiff, and they'd be better off if you hadn't done anything to them. And so for me, every year, when it comes to a slap tear, every year I do fewer. And I'll bet you in the last year, I didn't, and I do a couple hundred shoulder arthroscopies a year. Probably, I don't think I did more than 1 or 2 slap repairs in the entire year. And it gets less and less every year.
I just want to say I actually deal more with revision cases. I myself, very rarely I do a slap lesion, but I get patients who still have problems after an operate slap lesion. And it's mostly due to an associated impingement syndrome or a subluxation. So when I treat this pathology, they are cured. So
I think the biggest thing to look for too is make sure you examine them to see if they have any loss of external rotation. Because sometimes it looks like impingement because a stiff shoulder can force the humeral head superiorly, cause some pseudo impingement. But the real problem is they have a tight capsule. So you must release the capsule too and then treat the impingement but I think you look in the subacromial space, you will see if it looks normal. Like every time I do a shoulder arthroscopy, even if I don't have any clinical suspicion of impingement, I look in the subacromial space because that way I know what it looks like, supposed to look like. So after doing 1,000, then you say, okay, it's normal. So if it's normal, then I don't do anything in the subacromial space.
You know, one other aspect of that, and I'm sure as somebody who does a lot of revisions, you would agree, but one of the most important things about shoulder arthroscopy to me is the exam under anesthesia. this isn't like a knee. You know, I think I can do a pretty good examination of a knee in the clinic, and I don't need anesthesia to be able to get the knee to relax and get a very good idea about laxity. To me, that's not true in the shoulder, and I'll surprise myself about end range stiffness or end range contractures that I didn't appreciate in the clinic, or laxities anterior and posterior that I didn't quite appreciate in the clinic. And oftentimes when I do my exam under anesthesia, it really helps me to focus on the specific pathology that I really do need to address that I hadn't quite appreciated until I got to the operating room. So I would absolutely tell you that 100% of the shoulders you operate on should be examined under anesthesia before you prep and drape and get ready to do your operation.
I agree, and sometimes your assistant is so happy to get everything ready for you in position, you know, draped, ready for you for surgery. I said, did you examine the patient before you drape the patient? No. Okay, out. Everything off, re-examine the patient, then re-prep and drape and stuff. So I think it's very important.
What helps me also very much is before the surgery, I do an injection of xylocaine in the subacromial space, so the patient is relieved. So I know the problem. If it's not relieved, I do an intra-articular injection of xylocaine. Then if he's relieved, so the symptoms may mostly come from the slap lesion, if any.
Agree. Yeah. That's very, very important.
Selective xylocaine injections can be very, very helpful, as you say. You don't need to put cortisone in with it. Just do the xylocaine, and you'll get some information. I agree.
Yeah, well, the question is for the ACL talk. Rob, you've explained the success or the higher rate of success of the patellar tendon graft by the diameter, and therefore you're using a bigger diameter graft than before. Perhaps you're looking for an 8 or 9 millimeter diameter. But don't you think that the method of fixation may explain some of the difference in the success rate, or the healing process from the bone at the end of the graft as well? What do you think?
Yeah, I agree. I think some of the differences you can attribute to graft size, but bone heals to bone more quickly and more rigidly than bone heals to soft tissue. I think if you give it enough time, soft tissue to bone will heal just fine, but it's a little bit slower process. And I think for me personally, when I fix a bone tendon bone graft rigidly, and I've got bone to bone, first of all, the fixation is very rigid, so it doesn't slide. And I think that's then going to heal a little bit faster. And so I think that the quality of the fixation, the speed of healing, both tend to favor a BTB graft. And to me, the reason I think that I use that, let's go back. The question is, well, if allografts are as good as autografts, why don't you use allografts for everybody? And the reason is the speed of healing. I don't have an 18-year-old man, boy yet that I've found who will listen to anything I say. And so he's out playing basketball and he's out skiing 4 or 5 months after surgery. No matter what I say, as soon as he feels good, he's kind of good to go. And if you've done a BTB, they're probably going to be all right. If you do a hamstring graft or an allograft, they're not near healed well enough yet, and they'll have a much higher rate of failure. And so I think with hamstring versus BTB autograft, I think it's a size issue and a fixation issue both.
Yeah, we've done some CT scans of the proximal tibia, and within 6 weeks, you already have bone integration with the graft. So that's pretty amazing. You don't have to worry about fixation at that point because you already have some integration of the bone, surrounding bone into the graft itself. So that's, and like you said, you just get more solid fixation, I think, to get-go, which allows you to start the rehabilitation a little sooner, avoids some quadriceps inhibition type of problems as well. I'm sorry? I looked at just bone integration. Hamstrings are Sharpie's fibers, right? Sharpie's fibers at the opening of the graft. One of the things we talked about yesterday was, and Rob brought it up, the bigger grafts. So if you quadruple the graft, especially some of the systems, they make a socket 2 centimeters. I don't know if you need maybe 1 centimeter is enough. You don't need 2 centimeters because the graft, I don't know how much graft you actually need to have inside the bone because the Sharpie's fibers form right at the opening where the tendon goes into the bone. That's where the Sharpie's fibers form. So I don't know that you need a very long tunnel. And that would allow you to have a bigger graft available for the ACL.
But I think to answer your question, the basic science demonstrates good Sharpies formation and reconstitution at about the 12-week mark. And so it's a slower process. Once it's healed is healed, and then it's going to be good and strong. But it takes longer for a hamstring or for a soft tissue graft to develop a firm connection like a BTB would at about 6 weeks.
And because they want to come back, especially professional athlete, college athlete, they want to go back very fast. They don't take it easy for the first 12 weeks. They are moving moving around, and that may make it difficult if the fixation with the soft tissue graft, if that hasn't really incorporated yet.
With a quadrupled hamstring, semi-T graft, which is 7 centimeters long, does this compromise the tibial fixation? Do you need to do something extra?
You know, it's a good question, and there's conflicting data. One of the ideas that was promoted in a smaller hamstring graft, where in fact it is less than 8 millimeters and you're worried about re-rupture, is to augment it with a bit of cadaver graft. So you have a hybrid of autograft and allograft. And some of the studies looking at that showed, interestingly, a much higher failure rate in that hybrid graft than a smaller graft left alone. But there are conflicting studies that show that hybrid graft does pretty well. I haven't done enough of them to know personally what the right answer is, at least in my hands. But I'm a little bit worried about that hybrid because of the reported higher failure rate. Now, one of the other options is to augment it with a synthetic graft, an internal stint or splint that's being promoted by some companies. I've done ACLs long enough that I remember the ligament augmentation device, the LAD, that was polypropylene. It was used to augment ACL reconstructions back in the 80s. Now, a lot's changed since the ACL of the 80s and the ACL of the 2020s, but those did not do well, and there was a question about stress shielding so that the graft never got strong. So I don't know that there's a good answer right now that I could give you for what to do if you have a smaller graft, other than be very careful with your therapy and see if it'll heal more effectively over time. I don't know, do you have any thoughts about that?
The only thing I can say, there's a couple systems out there. There's a French system where they use one graft, only the semi-T. They never use the gracilis, but they quadruple it. And so almost uniformly, whether big or little patient, you have enough of a graft, at least 8, 9, more times than not, 9 millimeter graft. By not putting as much graft into the tunnels, you can make a shorter graft and have more tendon inside between the femur and the tibia. So I would evaluate whether the system you're using requires you to put too much tendon in the tibia or the femur. That's one system has 1 centimeter socket on the femur, 1.5 on the tibia, with very good results.
Thank you very much. We will close the discussion now and start the second session. Thank you very much.